Good afternoon. Let me just make sure I know how to work the slides. I'd like to thank Drs. Feldman and Keller for organizing this session and inviting me to give this talk today. I have no disclosures. Today, for my talk, I'm going to focus primarily or completely on the postoperative setting and discuss issues around opioid use, including persistent use, as well as disposal and diversion. And then I'd like to talk a little bit about the use of mobile health and how it may be helpful in improving patient outcomes, in particular around pain and opioid use. Opioid-related deaths have reached record levels in Canada and the United States. And the postoperative setting is actually quite a high-risk setting because it's often the patient's first exposure to opioids. And really, it increases their risk of persistent opioid use and diversion, which is actually not appropriately disposing of unused opioids and then having them used by others who get harmed by this. This series of papers shows that persistent use, or really typically defined as continued use after 3 months of surgery, occurs in up to 10% of patients who are opioid naive. These papers also suggest that the risk is higher in patients that are undergoing major abdominal or pelvic surgery. In general surgery, it's also been reported that the number of unused pills is as high as 85%, and this is coupled with less than 10% of patients appropriately disposing of their unused pills, leading to a situation that leads to diversion. While there has been some progress, published guidelines have not been widely implemented and have not resulted in altered practice, and therefore may not be enough to change this problem. Surgeons, and I'm one of them, continue to overprescribe opioids because we don't want our patients to be in pain. And there's little guidance provided to patients regarding safe use and tapering of opioids, as well as disposal of opioids. And this really underscores the need for multi-pronged interventions that are patient-facing. One of these patient-facing interventions is mobile health. And mobile health is a subcategory of e-health, and it's been defined as the World Health Organization as medical and public health practice supported by mobile devices such as mobile phones, patient monitoring devices, PDAs, and other wireless devices. There has been a recent systematic review on the use of mobile health in the postoperative setting. The inclusion criteria for this review was any clinical study using a mobile app in which it was used to facilitate communication between the patient and healthcare provider, and also provided some kind of assessment in terms of patient use, perceptions, and overall experience. The search used both Medline and Embase and yielded 257 articles. And of these, only 11 met the inclusion criteria, and of these 11, only 2 were randomized control trials. So I think this search really highlights that there is a growing interest in using mobile health, although right now there seems to be quite a lack of high-quality evidence about their effectiveness. The 2 randomized control trials that were included in this review had a total of 1,000 patients combined. The larger study by Janssen included 997 patients who were undergoing ambulatory day surgery. The primary outcome for this study was the score on the quality of recovery scale at 7 and 14 days after surgery. And the quality of recovery scale is a validated scale. It has 24 items, and they're rated on a scale of 0 to 10. The minimum score is 0, and the maximum score is 240. And just to be clear, the lower score represents better recovery. The results of this study showed that the overall mean score on the quality of recovery scale at 7 and 14 days was better in the app group compared to the control group. And similarly, the mean pain scores at 7 and 14 days were also significantly better in the app group compared to the control group. The smaller study was done by our plastic surgeons in Toronto, and it included 65 patients who were undergoing ambulatory breast reconstructive surgery. The primary outcome for this study was the number of in-person follow-up visits at 30 days, and this study showed that the app led to significantly fewer visits than the control group. Our own group has developed a program called Home to Stay, which is an integrated discharge monitoring system using a mobile app platform. It was co-developed in consultation with patients, and it's used to support patients at home after discharge following colorectal surgery. What the patients do is on the day before they go home from surgery, they download the app. And then once they go home, they receive an email to do a daily health check between day 1 and day 14 at home. The daily health check has a series of questions tailored to colorectal surgery that monitors the patient's progress and recovery at home. The patient's responses to the daily health check are then relayed back to us through a secure website in real time, and extreme responses are automatically red flagged and notify us that we need to call the patient to provide some additional support. The app actually sends a reminder to the patients to fill out the daily check every day. It tracks tasks for them, and it also directs them to relevant educational material based on the responses that they give. It also has picture-taking availability so that they can take pictures of their surgical incisions and the new stomas that have been created. In a pilot study of 120 patients, we had an uptake of over 90%, and the median number of entries per patient was 6.3, and the highest use was between 3 and 9 days. We're currently doing a single institution randomized control trial right now. The target sample size is 260 patients, and this is the interim results for the first 100 patients. And early on with this interim results, we're seeing a signal towards a decreased length of stay and 30-day ER visit with the app program. And we're also seeing an improvement in anxiety and well-being on the quality of recovery scale with the app. We've also just completed an opioid module to add to the Home to Stay program. And this will include the type and amount of pain medication that's prescribed to the patient. It will record their daily pain levels and how much pain medication they've taken. It will provide interactive information about tapering their pain medication and help them with a tapering schedule. And it will provide reminders of when the pain medication should be stopped, that they do not have to take all of their pain medication, and give instructions for appropriate storage and disposal of unused opioids. I think actually one of the most exciting and innovative parts of this program or this opioid module is actually the interactive tapering section of it. Usually when you look at a lot of the patient-facing information that's available on the internet, it tells the patient when they should stop taking the medication, but it really doesn't tell them how to taper the medication. And although it might seem very obvious to us that you should sort of decrease the pain medication every day, that's not always obvious to the patients who just take the pain medication as prescribed. So I think this will be an interesting addition to the module. So I think in terms of opioid mobile health and opioid monitoring, that it is definitely patient-facing. It's a way to prospectively monitor opioid use when the patients are at home. It's an efficient method of data collection as it's automated and you don't require a person to collect it for you. It provides the patients timely support. And I think it may also help healthcare providers facilitate early intervention if they see some alarming patterns in use. It will also assist to develop specific guidelines for opioid use following colorectal surgery, and there is the ability to adopt this to other surgical settings. So in summary, the postoperative setting is a high-risk setting for persistent opioid use and diversion. Guidelines are probably not solely going to be able to result in altered clinical practice, and therefore other interventions are necessary. And mobile health has a significant potential to help with this in order to support patients at home following discharge after surgery, as well as to help them with opioid use tracking and disposal. However, future randomized controlled trials are going to be required to assess the effectiveness as well as the cost effectiveness of mobile health before this strategy can be widely adopted into clinical practice. Thank you.